Hello and welcome to Inside the ER. My name is Dr. Patrick Garrity and I'm a practicing board certified emergency physician. Today you're joining us for a very special episode because today we have our first ever guest on the show. He is a vascular access expert as well as a speaker, educator, so much more, and much like Batman, known simply by his moniker, the Vascular Guy. Yes, I'm sure he has a given name, but he shed all of that and taken on this persona only. So without further ado, the Vascular Guy. Welcome, welcome. Thank you so much for being on the show. I'm very, very excited to have you on.
Thanks for having me. Very excited for your show. I know you just started, but it's such good content. I had to reach out and be a part of it.
I appreciate it, my friend. Before we begin, I'm going to let the audience in and a little tidbit. We actually know each other. We crossed paths many years ago, or a few years ago now. We used to work together in the same ER, and we have a mutual friend who got us back in touch. And there's some people that, you see them briefly, you have a brief encounter, but they still leave an impression. And when our mutual friend mentioned your name, I immediately remembered who you were. I was like, oh, of course, I knew who you were right away. Went on social media, saw your huge presence, saw your content. I was completely blown away by what you were doing. It was very impressive.
I hope it was for good reasons that you remember me.
Oh, no, of course, of
Man, I
course,
was
of
such
course.
a knucklehead back then.
Oh, yeah.
Shout out to Josh Kim for connecting us.
Of course, yeah.
He told me about your podcast and I listened to a few episodes. I was like, this is fantastic because I haven't heard of anything in the podcast space of a provider in the ER really diving deep into it. It's kind of like a big black unknown behind the veil, and you're really showing people what's going on behind the scenes because it's not how the damn TV shows are portrayed. Like ER garbage, Grey's Anatomy. I mean, some of the dramas there, but mostly garbage. I think the most realistic show is probably Scrubs.
Scrubs, always Scrubs. Every time it's Scrubs. It's every time.
So
Yeah.
yeah.
They're just doing their jobs. We're not having romantic, crazy trysts with the patients. There's not like a helicopter slicing people's arms off, like on ER and crushing people. No, this is the craziest. This is not happening. This is just, we're just doing our
There's
jobs, and there's some goofiness sometimes, but
there was one episode where I was like, did I hear that right? So in surgery, there was apparently a surgeon that had an IV because he was sick, so he just decided to
just
get some
saw this. I just
fluids.
saw this. Yeah.
Can you talk about that? Like why it's so
Yeah. I just,
ridiculous?
so this surgeon is about to do surgery. He's standing next to the anesthesiologist. He has his own IV in going to his bag of saline because I guess he's sick and he's going to operate, which also is like, do you really want this guy operating on you when he's got saline running? Is this really the best? Maybe there's someone else who can do it. The anesthesiologist goes to put the medication in, and then the surgeon looks at him and is like, oh, my arm, and realizes, oh, you've given me the propofol and the succinylcholine. You've given me the anesthetic and the paralytic. So he's like, okay, everyone, I'm gonna faint, and then I'm gonna go unconscious, and I'm gonna stop breathing, and and he starts prepping everyone. I'm gonna be intubated, all this stuff. My ICU doc friend who I work with sent me this clipped, and he was like, you know the problem with this? Here's the problem. He got succinylcholine. That's only gonna last for 7 minutes. Just bag him. Just put a little mask valve bag on his face. Just bag him up. He'll wake up in like 10, 15 minutes, and then he can operate. It's just completely craziness that this anesthesiologist would mix up the IVs and, oh, let me inject this one and just knock this guy over. So
What I thought was really funny was how lucid and how much time he
yeah,
had
he gave, oh,
after
I
the
know. Yeah.
injection.
Yeah.
I was like, dude, you'd be knocked out in seconds,
Yeah.
not 30
Yeah.
seconds.
It's
Like you'd be
ridiculous. I
gone.
know. It's ridiculous. And it was succinylcholine,
So yes,
which is a fast acting paralytic to the audience. So that's very quick. Yeah. It's very, very quick. Yeah. So funny.
like I was like, you must be doing some drugs on the side because you had a high tolerance.
Yes, that is a true thing. Listeners, if you're an alcoholic or use drugs, it's very hard. It can be hard to sedate you. You are very tolerant, unfortunately.
We found out a little bit about that surgeon.
Oh, for sure. For sure. I think since it's going up on both of our spaces, maybe we do a little more introduction of ourselves before we get into the meat of it. Does that make sense, Vascular Guy? You good with
That's a
that?
great idea. Let's do it.
Okay. So let me go first. So my name is Patrick Garrity. If you're listening for the first time, I'm an ER doctor. I'm a working stiff. I started this podcast inside the ER as a way to educate the public about how the ER works, how clinicians think. as a vascular guy noted, there's a ton of misinformation or confusion or media that doesn't really make sense, doesn't really jive what's actually happening. I think it's important for patients and their families and the clinicians treating them. I think everyone will do a lot better if everyone understands how the ER operates and how to best navigate it. When you're in the ER yourself as a patient, especially if you're stable, there's limited time from your clinician, your nurse, your PA, your NP, your doctor to explain what's going on. And so why things are the way they are. And so I think the podcast here, what I tried to do is to bridge that gap. There's not a ton of information out there for patients about how the ER actually works from a clinician standpoint. And so, like the vascular guy, I'm a clinician. I'm not an expert like he is. Don't get me wrong, but work in the ER for about 10 years now, have a sense of how things work. And as you can probably tell, this is a completely do-it-yourself podcast. I usually record in my wife's office, but she's working today. So I'm in the closet, her closet in our bedroom. These are her nice bags. Here's her nice shirts. I looked online and someone said, "Oh, if you record in a closet, it'll block out the sound." And I've got the baby downstairs with the nanny, so I've got the sound machine outside the room, hopefully drowning out any baby noise after I dropped my other kid off to daycare. So this is the do-it-yourself experience. Unlike the vascular guy, he's got set up over there. So when you listen to me, but also listen to him, we're not just some online people. We have experience. We have years of experience, years of training. We've been doing this kind of thing, what we're talking about for a long time. And so that's why I think it's important in these spaces to have these kind of voices who are not just people who are terminally online, don't actually not working. I'm working shifts. I worked a couple of days ago. I'm working a couple of days from now. We're both working shifts in that way. Vascular, I'm talking too much. Tell us a little more about yourself. What do you do? How you got started?
Sure. So got my license, went into pediatrics for a while, thought I'd do that forever, and then I got a little hungry for some acuity. Went into the ER at the hospital we both work at, and did that for about 5 years. Ultrasound trained almost immediately,
Mm-hmm.
and it was like the one thing I was good at. It was just dropping lines. And so they would call me for, hey, would you do these lines? And I'd barter with them, like, hey, yeah, if you watch over my patients for the time that I'm there, and they'd be happy to do it. And I was like, this is a great trade. We all very happy. I get to, abandon my patients for a little bit
Mm-hmm.
while
Mm-hmm.
my colleagues are taking care of them, covering, and then I get to do what I love, which is placing lines. And then Chris, the guy I worked with in the ER, he told me about this vascular access job, and he's like, "Hey, look, I heard you quit, and I know you're in between traveling. Do you want to come work with us for a little bit?" And
Mm-hmm.
this was in the middle of COVID, I believe, May of 2020, and so I joined in and fell in love with it. And I was really already good at it, got pretty fast tracked into getting the training and started diving into this specialty. And so that's where I'm at. And background is video production for 20, 15 years,
Mm-hmm.
DJing for 15, 20 years,
This is the
entertainment
difference.
business.
This is the difference. So this is the production difference. So this studio versus the closet. The closet.
All this is 20 years of making camera mistakes and figuring out what I need to do. So yeah, it's a long journey, love it, and finally I'm able to combine the
Mm-hmm.
two worlds together. So this is fun.
Awesome. Awesome. So vascular guy, when getting started out, right, we're talking about in terms of vascular access, talking about ultrasound guided IV peripherally, right, in a peripheral vein, like a superficial, not a superficial, but a vein in the arm, right? That's what we're talking. Is that the first thing we're talking about in terms of getting started, this kind of thing?
Yeah, absolutely. So ultrasound, to simplify it, if people are wondering if they're not clinicians, ultrasound is basically a device that can see under your skin through ultrasonic waves, just like sonar, and we use that to navigate the needle without going in what we call blind sticking. So I'm sure
Mm-hmm.
as a patient, you've seen people palpate, they tap on your hand or your forearm or your elbow, and what they're doing is they're feeling for the vein, but they're also trying to reinflate it. There's
Mm-hmm.
a hormonal response that when you tap on it, it'll actually start to vasodilate, so open up that vein a little bit more. And so they're doing that, trying to feel for it. And basically, they feel for it, kind of try to remember where it was, and then
Mm-hmm.
basically guess how deep it is. Um, the more you do this, the more skilled you are, the more you can tell the depth by what you feel. but it's still a very inaccurate, unprecise, not so precise method and technique. But it's what we've been doing for the last hundreds of years
Hmm.
of what we call vascular access and puncturing the veins. And now that we've discovered this ultrasound device, we can see under the skin. Now we can navigate it. And so the technology has caught up to improve this thing called vascular access.
Hmm. Yeah, so for people who don't know, we need to access the veins to draw blood for testing, obviously, but also to put an intravenous catheter in to give medications. I'm giving you fluid, antibiotics, a million things we need to give. We need to get in the veins. And for most people, most patients or a lot of patients, you can just do it looking at the arm. You look at the arm, you'll tie a tourniquet, right? You'll clean the area and you can see most of their veins. But there are a lot of patients who are very difficult to access, or they need some specialized care. They need something more than an IV. And so I guess the next question is, besides run of the mill IV in the arm, vascular guy, what other types of access are we talking about? What other vessels, what other applications?
It's a great question. So we can use this for arterial sticks, for
Hmm.
nerve blocks. I've done it for all of those domestically and internationally. So we use these to basically intervene under the
Hmm.
skin while seeing what's going on. There's another
Hmm.
technique called fluoro or interventional radiology does is using X-ray. What we do is use ultrasound, which is very, very non-invasive,
Hmm.
no radiation issues, very minimal to no tissue damage during this procedure with the rated devices that we use.
Hmm. Is there a specific type of patient you're thinking about for this besides the run of the mill? Oh, this patient, some patients they have poor veins for either because they're chronically ill or they've had some abuse problems. But is there any other patient you're thinking of, or okay, this is another one I have to access on? Maybe they need maybe explain what a PIC line is, or moving on that kind of more advanced from there.
Yeah, let's talk about let's separate
Hmm.
PIC lines, central lines, and PIVs.
Hmm.
Um, so PIV is a peripherally inserted venous catheter. Sometimes we call it PIVC, I think is now the new standard
Oh, okay, yeah, of
acronym for
course,
it.
yeah.
So the PIVCs that we place are short term generally, and they're shorter. So they're much
Hmm.
shorter, much smaller. Basically, they terminate uh, mid axillary is what I like to call it before the subclavian. Anything distal, anything from there on out to your fingertips is what we
Mm.
consider a peripheral IV
Mm.
venous
That's good.
catheter.
Yeah.
And that's probably the majority of what you as a patient will be concerned about. Everything else, you're going to want them to use ultrasound unless you're in a critical life-threatening situation or you're dead.
Hmm.
If you're already there, you're not going to care. You're not even going to be awake or even alive to feel it.
Hmm.
And so let's talk about peripherals, which I think is the most common issue for
Yeah.
patients. For me, as a specialist, and I know I'm going to get a lot of heat from the floor staff, I use it for all my patients. Even when I'm drawing blood, I will use the ultrasound. Even if that vein is
Wow.
so big it slaps me in the face,
Hmm.
I will use the ultrasound because I take pride in my primary objective, which is to give the patient the best care possible
Mm.
with my specialty and my skills, which means not poking you 20 times, not risking poking you 4 times or twice. It's getting it in once, the first time. And the reason why I care so much about and why our space cares so much about venous preservation and first stick success has been the term that we've been throwing around. Every time we puncture that vein for a blood draw, for an IV, for whatever, we're scarring your tissue. We're scarring your veins over time. And so because of that long-term consequence, for me as an ER nurse at the time, I didn't care what happened to you 3 years down the road. It wasn't my concern. In
Hmm.
fact, I didn't really care what happened 12 hours after because it wasn't my concern. What was my concern was at this time, you complained of chest pain. I need those troponins. I'm going to do
Yeah.
whatever I
Need some
can,
blood work. Yeah.
poke you as many times as possible to get that little bit of blood draw to find out if you're having a heart attack or not. Um, now that I look back, I don't think that's the best thing because now we have this technology to reduce those multiple attempts.
Hmm.
We have this thing called the ultrasound, and it's cheap now. The butterfly is what, $4,000. I'm sure there's cheaper devices out there.
Hmm.
Clarius, I think, is about 7 or 10 or something like that. Don't quote me on the numbers because I haven't looked in a while. But it's affordable now. We don't need to buy those $75,000 sonocytes. We can buy a handheld ultrasound just to get the IV access for much cheaper. So there's almost no excuse now with the barrier to entry being so low. So every time we poke you, just know, and I know the blood bank's not going to like this either. Every time we poke you, doesn't matter why. Every time we traumatize that internal organ, you're going to scar. And so I want to reduce that number of times that we've
Hmm.
scarred your veins, which is seeing where the needle is going. And so I have no excuse. If I miss a stick, that's a fail for me
Hmm.
because I either didn't use the tools that I wanted or I went for something I shouldn't have. And so sometimes we have to, and those are some mitigating circumstances, but or extenuating circumstances. But other than that, most cases are not extenuating. Even in the ER, not every patient is a code. Not
Yeah.
every patient is crashing. Not
Hmm.
every patient is septic or in shock. A lot of them are, but we treat everybody the same because it's easier on our bandwidth cognitively to just if you come into my this is what I did too. Come
Hmm.
into my room in the main, you get an IV. I don't care if you're here for foot pain or for you broke your finger or stubbed your toe. Everyone gets an IV. I don't have time to think about it. And I didn't know about the long-term consequences because I assumed that, oh, we poke you with a little tiny IV, you're gonna just heal like it's normal. Come to find out, it's not the case. So I've changed my practice because of what I know
Hmm.
today, and I'm hoping that will patients will be aware of that too, so that they advocate for themselves.
Yeah, to the listeners, it can often be easier to just get blood than to put an IV, right? It can be easier just to get a little bit of blood. And so when I have patients who don't need an IV, partly for that reason, I'll tell the nurse, no, they don't need an IV. Just get some blood. Let's less, a little less trauma, right? A little less. I want to spare that because you think everyone needs an IV. No, it's more traumatic. It might take longer. It's a catheter. It's in there now. There's more inflammation. So the vascular guy is talking about the scarring. If you get your blood drawn, a couple times a year, you go to the ER once a year or something, and they poke you once, it's probably not going to do anything. But if you're getting IVs repeatedly, right, these are long term. It's accumulating over a long period of time. So not that anyone listening is doing this, but yes, don't do drugs, kids. Okay, do not put stuff in your veins. It is very bad for you for many reasons. Part of it is that there's the reason there.
Can we touch on that?
Yeah, of course,
Uh,
of course.
because there are a lot of patients on my platforms where people are asking, "Hey, I do drugs. I know I'm not supposed to, but
Oh my
I
God.
want to know why is that going to make uh does it make it difficult? Why do when I go to the ER, why do they say, oh, they're IV drug abuser, it's going to be a
Mm-hmm.
difficult stick? It's because the chemicals that you're putting in your body, especially
Mm-hmm.
if you're injecting, even inhalation, it's the same issue. The chemicals that are not supposed to be in your body in that form are going into your bloodstream. And it's probably a dirty needle. It's
Mm-hmm.
probably you're trying a bunch of times because you can't get it.
Mm-hmm.
The chemicals are caustic to the vein. So what does that mean? It's chemically burning or chemically damaging the cells in the veins all the way through. And so it's almost like we're poking your veins from the inside with these chemicals and traumatizing them all the way through until it
Mm-hmm.
dilutes enough
Mm-hmm.
where it doesn't
Mm-hmm.
become a scarring issue. So that's why.
Yeah, for sure. I mean, it's multitudes, like you said, it's multiple things. You're maybe not the cleanest setup, right? So you're introducing infection that way. You get this needle, maybe it's not clean. You're maybe poking several times, and then what you're actually putting in there, right? And if you do it repeatedly in the same spot, that spot's scarred up. That vein's not going to work. You move around to the next spot, and all of a sudden you've got, So besides the fact that you've destroyed those veins and made any future medical access to you very difficult, right? Very difficult to accomplish. You've also introduced all these infections. So I've seen patients with horrible infections in these areas in their axilla, right? They're shooting up here in their antecubital, in the crook of their elbow there, in their groin, they're shooting in their groin. And just these terrible, terrible infections. And you can also affect the vessels around it. We have patients who inject in their groin and they hit their arteries sometimes on purpose. They're trying to hit the vein, they hit the femoral artery, and they do it occasional enough, and they cause this pseudoaneurysm, this ballooning thing that can then burst and just hemorrhage everywhere, right? And sometimes it's crazy that can happen because the femoral artery and the femoral vein, guys, like in your groin, like right below your hip, they're really close together. And so when I do an ultrasound guided central line, and I sometimes have to use the fem, I try not to, but if I have to use the femoral, they're right there, right? And I have to keep in mind, be very careful what I'm doing. And if you're blindly sticking, you might hit your fem, and it may not kill you then, but you're going to cause this crazy aneurysm, this pseudoaneurysm, this ballooning thing that's going to eventually burst or get infected, and you got big problems, among other things. So,
Yes. And when you go to the ER, I think an interesting thing is where else can they? My elbow's gone. They've used that. It's scarred. It's now diminished. What
mhm.
else? As a patient, what can I recommend? There is, I would avoid the hands, although if there's something in the hands and you're in the
If we
ER, you
need
got to
it,
get what you
yeah.
need to get. Yeah. But it's the worst place to put it besides the foot because there's no flow rate. Then without flow rate, there's no blood diluting the medication. So you get a
Mm.
lot of issues that way.
Mm.
However, there's the forearm, which is like right about from your wrist.
Hmm.
If you follow your thumb to your elbow, go a straight line. There's a vein here called the cephalic, and you can ask them to look there with the ultrasound. One of the most commonly missed is in the back of the forearm. So
Yes. Yeah.
here, the dorsal basilic is also a really good one. And so ask them, especially if you have a new nurse working with you, ask them to put on the tourniquet and look in the back of the forearm and see if anything's there. They'd be surprised at how much is back there,
Mm.
especially if there's a lot of collateral flow required. And of
Mm.
course, you have on the inside of your elbow, but also around the inside of your elbow. So a lot of people miss,
Yeah.
they see that big juicy one that sticks out.
Hmm.
Exactly, right there. And so sometimes there's ones that you can palpate. It's a little deep, but you can still feel them on the left and to the right of the elbow on the inside. And then one also common one that I see is in the upper cephalic is what we call it. So if you follow
Hmm.
from your elbow, if you touch your elbow and go towards the top of your shoulder,
Mm. Oh,
there's a
yes.
cephalic vein there
Yeah.
that's huge,
Yeah.
very superficial. And we can use that as
It's
well.
a very common, a
The
very
only
common, yeah.
caution, yeah, yeah, and if you tie the tourniquet all the way up, you'll see that starting to
It's like
pop up as
around
well.
your,
So those are
yeah.
some, yeah, and because this is a podcast that's directed towards more the general population, shouldn't the nurses know this? Shouldn't the doctors know this? Um, should is an interesting question because for the nursing side, we're not taught these things about vascular access. In fact, it's a huge gap in education because the schools are not getting paid to teach you a student
Mm.
how to do vascular access because they're funded, they're subsidized by the NCLEX passing rate. So the boards test that the nurses take, the schools are paid by how well they pass, not by the material that they know.
Oh, wow, no
Um,
idea. Interesting.
yeah, so that's why there's no incentive to educate on these things, and so we have to learn on the job. And sometimes, especially if you come across new nurses or non-specialists, they won't know all these special tricks because no one's taught them these other anatomical areas. So this is a little treat for you guys, a little hack and a little secret. As a
Hmm.
specialist, I'm handing it off to you guys. As patients, ask them to look and maybe cross your fingers. It'll be something they didn't know, and now you can
Yeah.
educate them as well
Towards
on
your
the
shoulder,
anatomy.
back of the forearm. Yeah.
Yeah,
When I
yeah, all
started
those.
residency, this was the intern vein, the cephalic you're talking about by the wrist. They call it the intern vein. Because they're like, okay, I can't get the forearm. Let me try this vein right here. Let me see if I can get it. Right. And so yeah, there's always the intern vein. Give it a shot. Um,
That's great.
yeah. Do you want to talk more about now, maybe moving to the more, I guess, pick line? Do you want to start with, you want to mention this, talk
Yeah.
about this now? Yeah.
So what is a PICC line? A PICC line is PICC. It's peripherally inserted central catheter. What does that
Hmm.
mean?
Hmm.
Peripherally inserted, we insert in the peripherals, which is your arms and your legs, and we insert and push the catheter following the pipeline of your veins to the center of the body.
Hmm.
If you want to start sounding really smart in front of your nurses and doctors, the catheter tip is terminating in what we call the cavo-atrial junction. There's a
Hmm.
little gray area spot called the CAJ, the cavo-atrial junction, where the atrium and the vena cava, the superior vena cava, kind of start to meld and meet together. And that's where the most optimal, most amount of blood flow is going to dilute the
Hmm.
vesicant medications or irritant medications. And so we do that because through the current studies, which I have my feelings about, they say that the peripherally inserted central catheters, the PICC lines, have the least amount of infection rates, which they do, compared to the other central lines, which go in your neck, in your axillary, in your
Mm.
subclavian, and
Interesting.
in your femoral, which is your leg.
Mm.
And so that's why we favor it because it has the least incidences. However, in my opinion, if you're doing these central lines properly and with optimal technique, there's no difference probably in the infection rates with your peripherals and your central lines. So that's a whole nother high level. You don't have to worry about that. Pick lines are most times to send you home with.
Hmm.
If we plan on just giving you these really harsh medications for a short time while you're at the hospital and then you're not going to need these medications after, we do a temporary central line, which is in the neck usually,
Hmm.
and then we just pull it right out.
Yeah.
Uh, but if we plan on sending you home with the medication to continue on, most likely we'll be doing a PICC line.
Yeah. So the very fancy, very dressed very well. Are we sewing still? Are you sewing? You doing adhesive into the, or how are you keeping it in there
It's,
mainly? Yeah.
yeah, no, I even with a port insertion, I won't
Hmm.
need to suture. Yeah. So we have these things called sutureless securement devices. There's
Mm.
the commonly known are the Secure Port IV, which is the glue. Then there's the Stat Lock, and then there's my favorite, which is the Secure Cap.
Hmm.
It's a subcutaneous anchor that holds onto that catheter. It's been the best one so far. It's a little expensive, but if you're using it long term, there's no reoccurring cost, and it stays with the life of the catheter. But there's so many alternatives to suturing, and suturing, there's so many issues with that. We're poking extra holes in the skin, which is
Hmm.
a nice little bio environment, friendly environment for bacteria to grow. Uh, the clinician can needle stick,
I hate
and
it.
that's not fun
I
when you
hate
have
I hate suturing these lines. It's so annoying. It's this extra thing you have to do.
HD
Right.
catheters, permacats, ports, like all those things, I won't suture. We
Mm.
have Dermabond, we have Exofin, we have the cyanoacrylate skin glue that we can use to keep that skin intact.
Hmm.
So
Hmm.
I've moved away from it. I know people are still suturing because it's in the kit, and when you ask the kit manufacturer why are you still putting sutures in, they say because the clinicians are still using it. Then yes, the clinicians, why are you still using it? Well, it's in the kit. So this big cycle
I
of
just expect,
we've
yeah,
always been
I'm
doing
like,
it
all
this
right, I'll
way.
just do what I've been doing and just, yeah, that's so true. Yeah, so
Bingo.
so the PICC line people that peripherally inserted central catheter, right? So what vascular is talking about, people that need these usually have obvious example is they have a serious infection and they need antibiotics for weeks. They don't need to be in the hospital for weeks, right? They'll be stabilized and then maybe they can be discharged and they might go to a rehab or a nursing home or maybe even home, right? With home nursing or even family and they need antibiotics. They might have something called osteomyelitis, which is an infection in a bone. That's a pretty common one where maybe they had a foot infection, the bone got infected, they had surgery, cleaned it up, but they still have some infection brewing. So they're going to be on antibiotics for several weeks. They need a line. My dad in the 90s, I guess, had Lyme disease and he got meningitis. He was terribly sick. And so he was home with this chronic IV and maybe it was I'm not sure what they were doing at that time. Might have been a PICC line even, but I remember I had this memory of him sitting in the living room with a bag hanging, infusing into his arm, right? And he, because he's very ill. And if I remember correctly, some patients need this. Obviously, this is an issue. And some patients go to nursing homes with this or rehab center. Some people go home and they're treated at home. Might have a home nurse, as I said, and get antibiotics. Other reasons to do it. That's probably the biggest one I'm familiar with. And these are great to have. And so when you have experts like the vascular guy putting them in, it's incredibly helpful. And we sometimes get lucky in the ER where the inpatient team and I can coordinate. Okay, this patient's getting admitted, they need long-term medication, and we could try to organize it in the ER, right? Which is perfect. But if it's not, you don't need long-term vascular access, then you maybe not need it. But this subset of patients is very, very important. I think we can talk about. Let's see if anything else you want to bring up the purely central lines now, which is what the thing I was, as a resident and then now as an attending, I make sure I'm up to snuff on because this is for me in terms of life-saving treatment. If someone's crashing and gonna die, I need to be able to do this. Besides placing to the listeners, you can place something called an IO, which is an intraosseous catheter. Basically, you get a little drill gun. It's got a little needle on it, and you drill into their tibia most of the time. You can go other places. You can go in the top of the humerus, like right below the shoulder, obviously. If you're dead or dying, you're not going to know I'm doing this, and I need to put some medication in you to try to code you to save your life. Maybe we'll do that. But if you're critically ill, but you're not flatlining yet, you're not coding yet, then I can maybe do the central line instead. I'm talking too much, but yeah, vascular. Yeah, so this is a line. Generally, I'll go in the neck, right? I'll go in the interjugular vein is what I'll do because it's what I've been taught. It's a little cleaner. I've gone in the groin many times when I have to for some extenuating circumstance. And so as an ER doc, you know, we don't we now do peripheral medicines more. We used to not do any peripheral vasopressors. So any medications to artificially raise your blood pressure if you're septic or you have some other serious illness. We used to never put them in the peripheral vein ever. This is years ago. But now we're doing that more as a bridge to maybe not needing it if you get better quickly, or a bridge to, okay, the person needs a clean central line with a vascular access expert or in the ICU, but I'm still keeping, for me, my skills up to snuff in terms of doing those central lines in case someone's crashing and I need it now. Sorry, I'm talking to. So why don't you explain a little more what we're talking about here?
No, this is great. So for the patients here, if you're not alert and oriented, we're going to do whatever we can to keep you alive.
Mhm.
That's and in the emergency room, even in critical care, if we can't get good access, it should be the IO, which is an
Mhm.
intraosseous, so
Mhm.
a needle through the bone.
No.
So we put a needle through the bone. That's actually not the painful part. It's the infusion of the medication
Yeah. Yeah.
that's excruciating. However, if you're not awake and you're dead or dying, you're not going to even
I'm not gonna
remember
know. Yeah.
that the medication was going in. So we do it as a quick way to access medication into your body. Let's table that for a second because those are pretty specific situations.
Yeah.
For the central lines, the so far a lot of the why do we avoid central lines is because there for the patients that are not familiar, there is a punishment called central line bloodstream infections. So
Oh, of
there
course, of
is
course.
a big financial problem for hospitals if you get infected or get an infection from a central line catheter, the one that goes in your neck, chest, or in your arm, doesn't matter. Any of those that get infected during your stay at the hospital will lose a lot of money.
Hmm. Hmm.
So much so that it can be in the multi-millions that they lose because of that infection. And we are still having a hard time managing. We know where it's coming from, and I can talk to you guys about that so you can advocate for yourself as patients and be aware of what's causing these infections. But we don't know how to manage it very well in the healthcare system. So much so that I think we're still, to this day, I have to double check the numbers for 2024 or 2023, but I think we're still in the over 200,000s of infections in the US. And so because of that issue, we are trying to not use these central lines. We're trying not to put it in your neck. We're trying not to put it in your chest. Definitely trying to avoid the femoral even before this issue. And
Mhm.
so there's a financial incentive for us not to insert these types of catheters. And so we're getting away from them in the ER and trauma and waiting for a better established, better technique, better environment to give you these harsh medications to the central lines. So that is a trend that's been going on, which I disagree with. However, I don't know
Mhm.
what the solution is, and we can discuss that as well. The trend is moving towards because they're finding that there's low the biggest argument against peripherals with vasopressors and these vascular
Mhm.
medications
Mhm.
were the infiltration and extravasation
Yeah.
incidences as poor outcome. Of
So the
course, thinking
medication
like
going
ER.
into the tissue, right? The medication's spilling out of the vein, going into the tissue on the arm. It's destroys. It's very, very toxic in that area. Yeah.
So the concern has been these medications, and they do, these medications when they come out of the vein and start leaking into in between the skin and the vein, so we call that subcutaneous tissue. So
Mm.
in that tissue, if you have these vascular medications, your tissues will start to die. They'll necrose, is what we call it. So necrosis is a fancy word for tissue death. And so it starts to damage the tissue so much that it's going to kill those cells. Well, if they're killing the cells in the subcutaneous tissue, why are we putting it in the veins? Why
Mm.
is that safe? Something called hemodilution.
Mm.
In your veins, we have blood flow. And with that blood flow, there's collateral flows, there's bifurcations and conjoining junctions. And so there's all these rivers, these creek beds of blood flow that's going to over time and over
Mm.
the journey to your heart in seconds, by the way. It's not minutes. In seconds of this
Mm.
moving of the medication, the blood starts to dilute the medication. So imagine this: a drop of lemon juice in your eyeball burns a lot, and it is very acidic and will damage your eyeball, I'm sure. However, if you had a drop of lemon juice in a gallon of water, imagine a
Mm.
whole gallon of water, and you drop a lemon juice in that gallon, and you take that mixture diluted with just water, and you take that and drop it in your eyeball, you're not really going to feel that lemon juice. The
Mm. Right.
molecules are there, but the concentration isn't so harsh. And so over time, because it's in your blood vessel, the blood is now diluting that medication so that it's not as harsh.
Mhm.
However, in your smaller veins, this is theoretical now because no one has really proven this yet. How concentrated or how diluted are those smaller veins? What's
Mm.
the flow rate? What's the blood flow? What's the volume depletion, the hydration status, where there's even any dilution or much at all? And as we know, if they're needing pressors, they're either pretty quite volume depleted
Mhm.
or there's not a lot of flow rate anyways.
Yeah.
And so there's that lack of hemoconcentrate, theoretical
Mhm.
still, but from what I understand, there's still vesicant effects
Mm.
all the way
Interesting.
up
Yeah.
in those. But again, this is still theoretical because the studies have not been done on my theory. And
Mm. Interesting.
what we know so far, why it's accepted in the trauma specialty in the ER is because we were only focused on extravasation complication, which is a big, serious problem. And
Mhm.
we're finding out that if we put it in right the first time, if we manage it properly, the complications of extravasation and tissue necrosis are low. And I do agree with that. I do agree that if we're monitoring, if we're vigilant
Mhm.
of complications, swelling, redness, patient complaining of pain, if we are listening to the patients and their symptoms of extravasation, then yes, we can manage it and prevent it from getting worse into
And
amputation.
as a bridge to
Um,
probably maybe a central line or something else, right? This is, as the listeners, it's a temporary thing, right? stabilize the patient
Bingo.
with this medication. It's a bridge. They're not going to be on this for a very long time. If they maybe they get better quickly and they can take off these medications that are maybe a little toxic to the vein, but if it's not, then okay, we move on now to a more invasive form of access, which is more invasive, but got to keep you alive. So we got to do what we got to do, right?
Yes. So one thing the reason why I bring all this up
Mm,
is I want to educate the patients who are listening. Yes, we got these medications in your loved ones and in you, and we're doing these vesicant medications. How long is it? This is a question that you should have for the clinicians. How much longer before I get this? I'm walkie-talkie now,
hmm
or walk or talkie, maybe not walkie, which means
hmm
that I can talk. I'm
Yeah,
conscious. I might
yeah.
not be strong enough to walk around, or my family member might not be strong enough to walk around. You guys stabilized them. Thank you for keeping them alive, keeping their blood pressure up to where they're not getting into shock. Thank you for that. It's been 6 hours.
hmm
Are we still running these medications? Yeah,
Yeah. Do we need
we
them
still want to
anymore?
maintain
Yeah.
the pressure.
Yeah.
So when is that central line going to get placed? So definitely keep an eye on that. It is very good for temporary measures to make sure we keep them from crashing. We don't want to tip
Mm,
them over to septic shock or hypovolemic shock or what have you, cardiogenic shock. But uh, be vigilant of how long you've had that going because
hmm
sometimes in the ER when we're like we got you a bed, we're ready to go, you're queued up, you're in line.
hmm
The critical care team came down, they talked to you, they taken you as a patient, and now they're managing the care. But
hmm
sometimes there might not be beds available because either there's staffing issues or the beds are full and patients are not getting discharged. And so now you're stuck in the ER for a long time. Definitely bring up, hey, when are we getting this central line? Because every minute that we're running these vesicant medications, it's damaging the peripherals. And now that's a lifelong,
Yeah.
possibly a lifelong issue.
hmm
And so address it. Yes, we need it temporarily to hold you over until we can get you a better line.
Yeah.
And we have
Or
protocols in
you improve
place. And
and you don't need it. But if you're most people are gonna need it, yeah.
bingo.
I'm lucky my ER,
So
my ICU team is like they're like this. Right. So if
they are
I
so
need
fast.
if I had to put the central line in, if I have to do it, great, I'll do it. I don't care. I do, but if the patient stabilizes, they look okay, and they're going to the ICU, they're very, very responsive, and they'll come. I've talked about this in my other episodes, so go to inside the ER .buzzsprout.com and look at other episodes. But the boarding is a huge issue in the ER boarding, and so we admit patients who might board in the ER for a long time. They're sitting there until they have a bed, and so hopefully you're at a place. I am thankfully where the inpatient teams, especially the ICU, is incredibly responsive and it takes over the patient because they know the ER is on fire all the time. We're managing other things happening at the same time, so they'll come and do this. Right. I'll go a little more. Sorry, I'm gonna cut you off. I want to talk more about what the central line is talking about. So the issue with the central line, besides the fact that maybe there could be a higher risk of infection, right? Because you're going directly into a central vein, right? And so that could potentially cause infection if you're not clean. It needs to be completely sterile, as opposed to a peripheral IV does not need to be completely sterile. What I mean by this is when we do it, when I'm doing this, right, I'm draping the person with this gown, exposing the vessel. I'm cleaning them up. I'm cleaning myself up. I'm putting this sterile gown on, a cap, a mask. I've got these sterile gloves on. Everything is sterile. When I open this kit to do this procedure, it should be sterile. Right? There's like a trick when you first do a central line as a resident, where someone tries to hand you a flush, and you say, "Nope." The flush is a syringe of saline. The fluid is sterile inside the syringe, but the syringe itself is not sterile. I need you to squirt the fluid into my sterile tray, and that is sterile. But you cannot hand me the syringe, right? These are little tricks they teach you, right? Just try to trick the resident to make sure they're doing the right thing. When you do that central line, besides the sterility part of it, there's all this hazing when you're an intern and when you're in residency. Besides the sterility part of it, the actual access, right? You're using some people don't use ultrasound still. I think it's totally crazy. It's like the craziest thing I've ever seen. You've got a tool,
Agreed.
use the tool. Just look. I love my colleagues, but I've been called into rooms before to help with central lines. and they're like poking the person. I'm like, what's going on here? And I just, because I've kept my skill up to be able to do this quickly, right? You got the probe, and guess what, listeners? The probe is sterile too, because it has a big sheath on it, a big little plastic sheath on it, which you have to have help putting on there, keep it sterile. You're looking with the probe with sterile ultrasound gel, right? Everything is sterile. Looking at the vein, you poke that vein, right? That maybe it's an internal jugular vein, maybe it's IJ, maybe it's a femoral vein. This big vein, they're large. Usually, you can get the poke pretty easily. But then this is more of a complicated procedure, right? The cell linear technique where you have to feed this. You get the vein in, you go in, you get this blood back. You know you're in. You're taking off the syringe. You have this little needle stucking in there, and you have to feed this wire in. This gets crazy. You have to feed a wire in into the vein to secure. Now I'm in there. I know I'm in. Remove the wire, and then you have to introduce the catheter. And usually you have to dilate. So you have to maybe make a little incision in the skin, and then you have to actually use a dilator to dilate the tissue. The vein itself is usually fine, but that tissue between the skin, subcutaneous down to the vein, and the vein itself needs to be dilated a little bit. Then removed, and then the catheter is introduced. And dear God, remove the wire. Remove the wire afterwards. And so that's a lot. It's a lot of to vascular access experts and ICU people and everything. This is run of the mill, and ER doctor does them, of course, and we do them pretty frequently, but it is a lot. It's intensive and it's time consuming. And it is, there's maybe a little bit of risk if you go in the wrong place, or it can be uncomfortable. Some patients can't lay back with this drape over their entire body. There's this complications there, it's one of the things I've kept this skill up, but it's not easy to do. I'll say that it's not easy, and it takes a little bit of time. And so there's a little bit of risk. I've never had anyone have a serious outcome from my central line, but a little bit of risk, and it's a little bit of situation there. I'll stop blathering. Anything you want to add to this interesting topic?
No, no, that's great. For any of the residents listening, or interns, or people who are in medical school, uh, I at this point I've placed hundreds. I don't think I've hit 1,000 yet, but I've hit hundreds of central lines all over the body,
Mm.
and actually probably thousands at this point for considering all CVCs. Uh, when I'm doing these invasive procedures, I always pucker up my cheeks a little bit. What does that mean? I don't disrespect the risks,
Mm.
and I'm always concerned that I'm going to screw it up. I don't treat it like, oh, I'm so good at this.
Well,
I
I'm
mean, I'll
fine. I'm
say
fine.
that to you. Yeah, like, yeah, this is nothing.
It's
I can
fine.
put
It's
this in
fine.
2 minutes.
Yeah.
Yeah, let's go, right?
Yeah.
Um, so I always take it extremely seriously, because as an RN, if I screw up, I don't just get a slap on the hand or the wrist like residents do. I could lose my license,
Mm.
more likely, and there'll be a new law passed or new rule. No nurses can ever do this because of one bad outcome. Even though I've done thousands of these, one bad outcome because that person was a nurse and they screwed up, even though tons of providers have done worse, it's still a bigger deal. And I treat it as such. And I think everyone inserting these lines should have the respect for the risk. Luckily, no arterial punctures, no pneumothorax, no thyroid insertions. So
I'm sorry.
luckily, yeah,
Sorry. Oh
yeah,
God, that's
yeah,
terrible.
yeah.
That's
I've
terrible.
I've heard
Yeah.
of the craziest things.
Hmm.
And so that's why I use all the tools I can to make sure we give the best possible outcome. It's for me, and this is uh, uh, the best advice that was given to me. Change your objective. When I had a bad day or a bad missed insertion, luckily I didn't, keep
Yeah.
poking them a bunch of times.
Yeah.
I just couldn't get
So
access, and I bailed out, and my mentor took over the
yeah.
insertion. And he was like, you know, I was kind of down on myself. This is at the beginning of my training. And he said, you know what? I want you to change your perspective, because you did the right thing. You tapped out with one attempt and you didn't advance that needle like 20 times. So you did the right thing by tapping out when you couldn't see it and let me take over. He said, you need to continue to change your objective. Your objective now as a specialist is not get the line in. The objective is give the patient the best care, and that means you bail. Because if you keep trying, that's where providers who are doing these lines, even nurses who are doing these lines, they're going through the carotid. They're dilating the carotid because they're like, oh, it kind of feels iffy, but I want this to be a win, so I'm going to roll the dice on the patient.
Yeah, you don't
And when
don't
he explained,
dilate the carotid artery. It's very bad to do that. Yeah. The dilator. Do not do that.
and and it's happened, and it's still happening today.
Mhm.
And so he gave me that was the best advice was your goal is to give the patient the best outcome. If it's you bailing on the procedure before you go more invasive, which is the dilation part, then you should pull out. At least there's a small hole.
Yeah,
The
it's
body
fine.
can clot that very
That's fine.
easily.
Yeah.
Put some pressure and then let someone else do it because it's just going to snowball into something worse if you keep trying. So, one
Huge.
advice also for these younger clinicians listening to this podcast is low IJ insertion, turn it down to the chest. You're going to reduce infection risk significantly because the dressing disruption when you tape it to the neck is what causes the infection. The film barrier, that
Oh,
dressing
I
is
see
key.
what you're
This is
saying.
for
Yeah.
patients too.
Yeah.
For the patients, the transparent dressing, the tegaderm is what you probably heard us call it. That is what's preventing things from going in the hole that we just created.
Yeah.
But if that's loosey goosey or gone, because when we move our neck and all this flexion, there's one, two, three axis of movement that'll disrupt that dressing off. And so that's why nurses are having a hard time keeping that from getting infected. So if you just start low and turn it down to the chest, that's going to help
Yeah.
that gravity
Interesting.
from
Interesting.
fighting you. And
Yeah.
so you're using gravity to work with you, and that dressing is intact. Your nurses will love you. And so that's the biggest thing. It's free. You don't have to pay for a new device. You don't have to pay for
Mm.
a specific catheter. You just turn it down to the chest, and that's going to be probably the best outcome for the patient.
Mm. I love what you said about that and about knowing when to back off, right? As I've had colleagues who said, "Hey, Garrity, I can't get this. Can you help me?" And of course I can. I've done the same thing. I was a resident. I remember one time residency, I had this patient who was demented. He was screaming. Couldn't get him from stop screaming, screaming, screaming. I could not get this I couldn't do it. And my attendant came in, helped him when we got it. And I called him in not too late. I was like, "Hey, I can't. I need help. Please. I'm sorry." You know, I want to mention, more about this in the fact that if you're a patient, because you talked about the nurse situation. If you're a patient, you might think, oh, the doctor is the best person to do everything. That's not true, right? That is not true, right? The doctor, the PA, the MP, the nurse, the tech, everyone has a role, right? And you've got vascular access experts or people who are shout out to Josh Kim again, who is incredibly good at doing ultrasound guided IVs. Right? He's incredibly good at that, and it's a huge help in the department. We have people who are different specialties and are very good at different things. We recently had a patient, and I admitted, my friend admitted the ICU wasn't my patient. IV drug user, very agitated. She's got no arm. She's missing an arm, right? So she did a bunch of drugs before. The arm is gone. It's amputated. The other arm, she's clearly still injecting. This one is like a withered husk, and she's just screaming and writhing, and they have trouble sedating her. The ICU PA comes down, puts in that central line like it's nothing. And I was so impressed watching her. I could not believe it. I was like, this is amazing that you're able to do this because it would look very difficult to me. And I've done this for a long time. I was like, wow, but people are good. They have specialties, right? When I was a resident, I remember one time we had this attending who worked sometimes who was not clinically experienced anymore. Let's put it that way, right? You have some attending physicians at these academic centers who don't do a lot of clinical work anymore, right? And it's okay. You're getting older, you're teaching more, you're supervising more. It's understandable. And so you have to know your limits, right? I'm still in a community setting. I'm still doing all this clinical stuff. And I teach a little bit, but so vascular guy, they were doing an IJ. It was very simple on this patient, right? It looked like a pretty simple procedure. I was hearing about this, and they go to dilate, right? So they put the needle in, folks. They're in the right spot. They put the needle, sorry, the wire in to secure, take the needle out. use a little bit of a scalpel, a little bit of a poke just to dilate, just to get that skin going. And then you feed this dilator, this plastic hub over the wire, which you're going to pull out when you're done to put the catheter in. He puts the dilator in. And for me, when I dilate, I go about like halfway on that dilator when I'm doing the neck and the IJ. I don't dilate. It's not necessary. The skin is not that thick. And the attending's like, go all the way. My friend's like, what? It's like, push the dilator in all the way. And he's like, I don't think I should do this. But this guy was like the head of the department or something. We had to do what he said. He's like, all right. And he put the dilator, the effing thing all the way, and he like hubbed it, which is a terrible idea. And then he pulled it out. And guess what happened? This blood just came out. And then the attending's like, you're in the artery. It's like, I'm not in the artery. We don't normally dilate the tissue this far. That's not what we do. And so the patient did fine. They just redressed and did it again. But I heard about this after the fact. It's terrible. The point is that you want the person who's skilled at what they're doing to help you, and the person may not be a gray-haired white guy, right, who is the head of whatever, right? That's not, maybe you want the person who knows what they're doing, and you may not expect it. Like, oh, this younger doctor is more skilled. This PA, this nurse, this RN is actually the one who's going to do this procedure because they're the one who knows how to do it, right? So that's if you go to an academic center, you might encounter this where the oldest person, the most experienced person, may not be clinically up to snuff as much anymore, right? Or maybe they are, but it's not always, you want to just kind of follow the lead of the team taking care of you. They know who's going to do what, who's effective at what.
Yeah, 100%. It's a tactile, it's a procedure. Like technically a proceduralist. It's a tactile skill. I have an age limit to this. Like there's only so many
Mm.
years I can do this before my eyes go bad,
Mhm.
before my muscle memory isn't as good. And I've seen it with, with the people around me, the other specialists who are now amazing educators and amazing clinicians as well. I mean, they still got it, but um, I know that there's a limit to this and it's an aging
Mhm.
skill. And so, that's with the higher level stuff. It's a procedural skill. Look, I can get your IV in probably the best experience. People have told me, even patients have told me, this was the best IV I've ever gotten.
Nice,
What's your
nice.
phone number? How do I get a hold of you? And so this is off of public review of why I'm saying this, but no one has ever said that about my vaginal urethral catheterization. So if you're female and you want me to catheterize you, trust me, I'm not the guy.
Hmm.
I'm not that guy. I will, it'll take me a few attempts. So we all have our skill sets. And so just because someone is practicing with this license or at this level, make sure that they're also good with what you're asking them to do.
Hmm.
Just because we're good at one thing does not mean we're good at everything.
Of
And
course. Yeah.
so keep that in mind. Yeah.
Any clinicians listening, you have to know that as well. What your barriers are, what your gaps are, right? In terms of intubation, I pride myself on being very good at intubation, but I have a procedure, right? And I'm not cocky, like I said before. Every time I intubate, when I put the breathing tube down their throat to put them on a ventilator, I'm always a little nervous. I have to be a little nervous because there have been times I've had issues, I've had problems. I'm very lucky in my ER. We have an airway response team I can call if I can't get it or if I have trouble. And I've called them preemptively. I've been like, hey, I think I can get this. I want you here if I cannot, in case I have an issue. And most of the time I've still gotten it, but I know my limits. I know, like, I'm always prepping. I'm always like, okay, have the suction, have this, have the bougie. This is like a plastic catheter you can put in it. I have all little things set up so I know where to go. I wanted to, unless there's something else, I wanted to go back on about something about the central lines because I realized something. This is more for younger, like starting out clinicians, I should say. So the cardinal rules beside for if you're putting a central line is we said this, don't you can poke an artery, right? You can poke it, but you cannot dilate it, right? You can poke it and say, oh, I'm in the artery, pull back. Do not dilate the artery. When you are using the scalpel into the skin to near the wire, do not touch the wire. Do not fray the wire with the scalpel. There's probably more cardinal rules. And the last one is do not lose the wire. When I was a resident, every year someone lost a wire. By lose, I mean it was still in the person, which is very, very, very bad. And it's every year someone did that. And every time it happened, Vascular Guy, talk more about this if you have experience with this. They had to do it twice. They had two kits. They tried, they couldn't get it. They got another kit and they tried again and they forgot that there were two wires. And so every time I do it, I hold the wire up like a trophy. I'm like, here's the wire. And I like throw it. I'm joking, but I like throw it across there. I'm like, here it is. The wire is gone. I had a friend who did this. They tried to go in. They fed the wire. They couldn't dilate. Something was wrong. And they pulled out completely and forgot to pull the wire out. And the wire went in. Another friend this happened to where they forgot to pull it and it was still in the catheter, thank God. And so they clamped the catheter and pulled the thing out. And that patient was okay, thankfully.
Yeah, and if you do dilate the carotid, you'll see it shooting blood out pretty fast.
Very bright.
Uh,
Very,
don't,
very.
yeah, you'll see very bright red blood. Don't remove that dilator. Actually,
Oh,
you know what? In
interesting.
fact,
Interesting.
finish your procedure, put the catheter in
You've already dilated, I guess.
because it's
What's the yeah,
already
yeah.
you've already dilated it. Now you can tape this soft catheter to the body and transport them instead of having to hold that dilator in place. There, you can't
Mm,
tape that dilator to the body very easily. So if
interesting.
hopefully
Interesting.
you're there and you're not the one that did it, maybe this will stick in your brain and you can actually keep the patient alive if someone else is doing it.
Mm,
And if you ended up doing it, then this is what you need to do to keep them alive. Keeping them alive is key. There's one thing accidentally perforating the carotid, but it's another thing for them to die from it. So if you want to prevent that hemorrhage, you finish out the procedure, put the catheter in, keep it there, now tape it down so that surgery can go in and fix it. Now you have an impaled object staying in place
hmm.
to hold the blood in place so that surgery can get to it later.
Exactly. Exactly. There was a
So
patient
many
in
people
yeah.
pull it out like, "Oh, I don't want people to
Oh
know
my
it's me."
God. Oh my
And then
God. That's
and then they
terrible. Yeah.
pull it out and now we definitely know it's
It was
you.
you. Yeah. Because guys, remember
Yeah.
uh, that you've dilated the tissue all the way down and dilated the opening of the hole you made in the artery. Compressing that externally is not easy to do, right? It's not just a little poke. It's all the way down this. It's really hard to compress that situation. And it's their neck. It's not very comfortable to do either. So if you have something in there, almost a tourniquet, if you're stopping it up with some catheter, I've never even thought of that. It's very interesting.
Here's something to encourage you guys to really think about this and kind of replay it in your head before it ever happens. Dare I say, it's impossible to stop that bleeding because you
Mm,
don't have bone or lots of muscle to back pressure against. There's nothing there. It's all soft tissue. So if you apply pressure here, it's pretty much just going to shift everything. Then you
wow.
have your spine there, but you'll be lucky if you can even maneuver that carotid. That
Hmm.
carotid is going to shift. And when it shifts, there's this sternocleidomastoid. There's other structures there that's going to prevent you to apply enough pressure. So you might put some pressure, but dare I say, it's never going to be enough to stop that carotid, especially because there's so much soft tissue there. So best thing to do is finish out that procedure, put the catheter in there to stop the bleeding and then because a catheter is going to be uh, soft enough that you can just tape it down to the body and
Mm.
hopefully
We'll stop
that
some of
bleeding
the
will
yeah.
slow down to
Hmm.
clot. Yeah,
Hmm.
yeah,
Interesting. That's a great idea.
that's a good one. I haven't talked about that in a while.
It's very yeah. I haven't. I don't think I've actually seen it. I've been part of cases where we poke the artery, and I was like, "Oh, stop, pull out, hold down pressure," and the patient's fine. And I've seen these wire people before. Or this thing, the the issue, guys, if the wire, this long, literally a wire, goes in right, and then gets floating around in you. It's very bad. Okay, it can cause damage. You can die from this, and that's why it's very important that if you're listening to your clinician, keep that wire out.
Yeah, and it's usually because they underestimate how long that wire is. Even during
Oh,
my insertions, you never really need to go more than like 60% of the way in.
Oh yeah.
And so I think people insert, I mean, it's an 80 centimeter wire. You don't ever need to put all 80. So do your measurements. And if you can get a hold of like a practice kit, look at the measurements between the IJ and the cable atrial. And then look at the length of that
Yeah.
guide wire. Now you know how long you actually need to put it in.
Hmm.
You don't need to go once you're in the SVC, you don't need that wire further down.
Hmm.
Um, when you start to elicit VTAC when you
Yes, when you
hit that ventricle. You know you went a little
so
too
yeah.
far. So
We had
let's
yeah.
shift gears if you don't
No,
mind.
of course, yeah. We need to talk again in the future and
With
we can share more of these crazy stories we have because there's so many of
the
them.
war stories.
Unfortunately, yeah.
So what can patients do to get ready? I think that's a really
That was my next
interesting.
question I was going to ask you. I'm looking at my that's perfect, yeah. Yeah.
Let's talk about how patients can get ready to get poked.
Mm.
Um, long term, and of course, you're here because you're sick and you may not be able to. But long term, for those of you who are still young, still mobile, uh, exercise is key, and a specific type of exercise. You have to work out the muscles where we can access your veins, which is your arms, curls, forearm. And if you're not a weightlifter, that's totally fine. Knitting all day,
Oh,
every day, sewing, anything with your hands, video games,
yes.
whatever moves and contracts those muscles will create a demand for the vessels to be bigger. You lose what you don't use. So if you're not
Mm.
using your muscles, if you're not requiring oxygen exchange and blood flow to that particular part of the body, your body is going to reallocate those tissues to elsewhere. So if you're not exercising that part of your hand, your wrist, your forearm, your grip, your elbows, if you're not moving all those parts of your body, your veins are going to become smaller because your body's saying, hey, I don't need as much blood return here because you're barely using this thing. I'm going to reserve the proteins, reserve the building blocks for somewhere where you are using it more. And so you become venous depleted with lack of exercise. There's low pressure. It starts to get stenosed. So there's all these issues. So that's one thing long term. It's too late. You're already 65 and 55 with all these issues, and
Mm.
we're having a hard time poking you. Uh, get very well hydrated.
Ah, very good.
So if you don't have congestive heart failure, all
Mm-hmm.
these AFib, all these backflow issues with your blood, then hydrate. Drink lots of water. Yeah, there we go. Here we go. Cheers. Drinking water and being hydrated is key. I would say if you're if you have some time before you need to go to the ER, or you know you're ready to go, but it's not like life threatening yet, but you want to make sure it's not, and you have like a couple hours or minutes before you need to go, drink until your pee is almost clear. That
Mm-hmm.
indicates to me that you're overhydrated, and that's hopefully going to inflate your veins like a
That's
water
perfect.
balloon. It's
That's
going to
perfect. Yeah.
inflate your veins for the clinicians to play with. Um, Another thing is allow the nurse to apply that tourniquet for a little bit longer.
Mm.
Let them know, hey, I haven't had a chance to drink a lot of water. I didn't want to pee while waiting in the ER. So I'm a little dehydrated. Can you please just keep that on there for a little bit longer?
Interesting.
There's
Interesting.
some issues with that. If it's a blood draw, they may not be allowed to. There's a
Mm.
whole issue with that. Don't worry about that. But if they need to put in an IV and they don't need to worry about specific blood draws or labs that need to be done, then ask them to keep it on there before they try. If they're poking you, slapping your veins, which those of you who are still flicking that vein, stop. This doesn't help. Just you can just bounce the vein. You don't have to flick them hard. So if they're feeling for it and they're taking a little bit of an extra time, you're starting to get nervous because they're taking a little bit more time feeling for your
Mm.
veins. Because they can't find it. Ask them, hey, can you just keep this on for a little bit longer and just I'll let you know if my fingers turn blue, but can you just
Mm.
keep it in there?
Interesting.
Because sometimes if you don't have enough blood volume, you need time for that blood to back up to the tourniquet. And
Interesting.
so it may take a
Interesting.
little bit longer for that tourniquet to reinflate your veins. So ask them, can you please just keep it on there for a little bit longer? And again, blood draw is a different issue because of hemoconcentration. You get falsely elevated lab levels. That's a whole different topic. But if it's just cannulating an IV and just putting in an IV, then ask them to wait with that
Mm,
tourniquet.
interesting.
Oh, another thing, lower your arm and ask them, hey, can you, if you need to, if you can't sit down, nurse, if you can't sit down, or if you need to stand up, can you raise my bed up? And I'm just going to lower my arm and get my hand to be as close to the floor as possible. So
Oh, yeah.
use gravity to your advantage. So that'll speed things up. Because if you
Mm,
have your arm up here or, not as, if it's at all elevated, the more elevated it is, your hand, the less likely that blood will pool at your veins. It'll probably get to the tourniquet, but
hmm.
those are the deeper vessels and they can't see that. So what you want to do is have your hand or your fingertips pointed down towards the ground so that gravity can help waterfall, can help pool that blood faster. And so that's another way to help to reinflate your veins.
That's
These are like
perfect. Yeah.
small,
Yeah. You might only need a
little,
little bit.
it's going
Only a
to
little bit. Yeah.
yeah, it may bump up your chances by like 2%, but it's 2% rather than none. So it's not like these techniques are going to guarantee them to get it, but it'll definitely help a little.
Love that. I love that. I did write in my notes. I was like, should we do more bicep curls? I was going to ask you that question. Should I be curling more? Is it going to help with the
Yeah,
veins? I think so. Yeah. I think it's going to make, well, one of my friends in residency was incredibly jacked and his veins were like from a mile away. You could see them. So I imagine there's something there with getting out with a little bit of exercise. Anyone can beef up their veins a little more.
100%. Yep. Those curls will help. Any movement, any contraction of the muscles around the veins that you want to get bigger. And we're not talking long term. I'm not talking about a month. I'm talking like 6 months to a year
Yeah.
is
This is, yeah. I mean,
what I'm talking.
everyone needs
Minimum,
exercise, of
minimum.
course, but yeah. Yeah. Yeah.
Bingo, bingo. So that's a long-term strategy and it's the best one. Okay. Another question was bruising.
Oh yes, I was gonna ask you about this. The question I had was, I remember hearing this. Like I was like, oh, the bruise you might get if you're getting poked just a venipuncture for blood work or getting an IV. Is that bruising because of your clinician, because of your nurse, whoever? Is the bruising because you didn't hold pressure long enough? What's your take on that?
So are you talking about bruising after removal or bruising with the catheter in there?
I guess after I was thinking about, but we could talk about both if you have. I wasn't thinking about it
Okay.
during. Interesting. Yeah.
So let's go by the sequence of events and start
Hmm.
with bruising with the catheter in there. Hey, my catheter's in here, but it's bruising. What's going on? There's a couple of scenarios. One, it's not actually in the vein. And so you're bleeding. So they poked your vein and they did something or something happened. It might not even be them, but something happened where the catheter's now out of the vein and you're bleeding subcutaneously.
Hmm.
That's one scenario. Another scenario, it's rare, but it does happen, is you're usually people with connective tissue disorder have this issue, whether due to old age or due to pathology or an illness. Uh, the back pressure from your veins pushed the blood around the catheter and out into your subcutaneous tissue. So most times it's because a tourniquet was applied too long after the
Hmm.
catheter was placed. So the blood starts to squeeze around the catheter and out of the vessel.
Interesting.
Um, or in general, their body the connective tissue disorder prevents that tight seal around the catheter. And so it just starts to leak. And the
Hmm.
hemostasis, that slow leaking, initially it'll leak it out into the body or into the subcutaneous tissue, but it'll clot over time. So there just wasn't enough time for it to clot as quickly. because you're taking anticoags, you're taking medications, or your body just has some kind of hypocoagulability there.
Mm,
Um,
interesting.
so that's if the catheter's in your body and you still are bruising. Now, if we've removed the catheter and you start to bruise or you bruise easily, is what people have been told, most likely you're not applying pressure at that site for long enough. Here's why. Every person is different depending on medication, hypercoagulability or hypo, which means that your body does not clot as easily as other people or as quickly for
Hmm.
whatever reason. And so for you, we need to apply pressure so that we close off blood flow to that vein for long enough for your body to clot at that location. If you don't apply enough pressure, what'll happen is for me, I only need, I don't know, maybe 30 seconds, maybe a minute for it to completely clot and not bruise out. So
Interesting.
I'll
Yeah.
apply pressure for about a minute, and I know that after that, I'm good for my body. But for some, it might take a full 3 minutes, which is a very long
Oh yeah.
time.
You're on a
It
blood
doesn't feel like
thinner,
it.
you're on an antiplatelet, you're on some anticoagulant medication for sure. For sure. Yeah.
Bingo. So you're getting blood drawn because you're sick.
Mm.
So you most likely will need to hold pressure for a lot longer. So my recommendation is put a timer on if you can, or look at a clock. Put pressure as hard as you can at that site for a full 5 minutes. And
Ooh,
that is
that's
a
good.
very long time. You'll get tired, trust me. But put as much pressure as you can for a full 5 minutes. That tends to be enough.
Mm,
Hemostasis is what we call it. Enough blood slowing down to really coagulate, really clot that opening that we've created.
love that. I love that. It's way longer than I would expect. Next time I get blood drawn, keep that in mind.
Yep, yep, yep.
So, Vascular Guy, thank you so much for joining me. It was a great conversation. I loved it. I got a great time. Where can people find you? Anything you want to promote or spotlight?
Yeah, they can find me at anywhere except for X or Threads. I don't have the bandwidth for those types of platforms. YouTube, Instagram, TikTok, LinkedIn. You can find me at The Vascular Guy. Very simple. The same thing.
The Vascular
hmm
Guy.
So you can find me there. One thing I'd love to plug, if you're a patient here and you have these long-term vascular accesses or you're concerned about something or you want to educate yourself, I do have an AI startup called intracav.ai.
Oh,
So
yes,
that's
yes, yes, yes.
INTRACAV.ai. This is built for clinicians, but because it's AI, it can actually be dumbed down and simplified for patients. So if you have a very specific question about, hey, what I have this line, I just got it. I've got this Hickman Broviac tunnel catheter, blah, 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 blah. And I forgot half of what they taught me at the hospital. Use
Hmm.
IntraCav
Hmm.
to educate yourself very quickly and, in my opinion, very easily on what to do about your catheter. I think a lot of people kind of get thrown to the side when it comes to this education stuff. And so we've created this tool for both clinicians and patients to know how to handle their catheter. And if you're seeing a clinician
Mm.
do something really weird and you're like, I don't know if that's the right thing, and they're not explaining to me why they're doing it this way, it's a little sus, a little suspicious, or I don't know. I want to verify if what they're doing is the right thing to me. You can look it up and check it with Intracav. So I highly encourage that. That is a clinical specialist tool for vascular access specifically. And so I highly encourage if you're living with these catheters, you really should be educating yourself on how to manage it and take care of it. And so Intracav
I love
will
that. I love
help you
that.
do that much more easily than Google. Google will take forever.
Oh yeah, I'm gonna give you the wrong, and you get some bogus information that you're gonna about your
Bingo.
health. And so yeah, so definitely check out the Vascular Guy, Instagram, TikTok. While you're at it, you can take a peek at our website. It's just a place to listen to the episodes, but so inside the er.buzzsprout.com. Buzzsprout is Buzzsprout. Find Inside the ER anywhere you listen to podcasts. If you like this episode, give us a shout. Maybe you want to tell someone about this episode or about the other episodes, about the vascular guy, someone with a chronic illness, someone who's training in the medical field, wants some more information to get this kind of access. So I think we're good. Vascular Guy, thank you so much. I appreciate it.
It's been a pleasure.
You can send in your comments if you want to email the show. You can send in your comments and explain to me what TikTok is, because I still don't quite understand what it is. But if you want to try to explain it to me, that'd be great. At insidetheer@gmail.com. Vascular Guy, any final words? We're good?
No, appreciate you having me, man. It's really nice connecting back, and I think your platform's gonna be really good for patients.
Awesome, man. Thank you so much. Appreciate it. Thanks for listening, and all the best.